Good morning. I would like to express my thanks and congratulations for the perfect organization of the Congress to the President, Professor Kouros, to Professor Rigas, and to all the organizers. Very perfect. I participate to many Congress, but this organization is very, very, very good. My paper concerns psychological and clinical aspects of the pre- and the perinatal death. It's a long paper, but I try to summarize the most important point because the time is short, and so I try to summarize. I'm sorry that if they are not so precise, but I can give you the complete work later. Losing a baby during pregnancy or after childhood, or after childbirth is not a rare event and involves parents from all over the world, regardless of age, socio-economic level, or ethnic group. Epidemiological studies conducted at national and international levels reported incidence rates for miscarriage and intrauterine death between 15 and 20% of all pregnancies. Most of the loss occurs in the first and the second trimester, although the latest studies describe a worrying trend of increasing of intrauterine death in the last quarter, particularly in the weeks immediately preceding the expected date of the birth. In Italy, the miscarriage and the death in utero concern about a pregnancy of 6. In many cases, it is not possible to identify a precise cause, and the death of the child can also occur at the end of the asymptomatic pregnancies without complications. The loss of a baby during pregnancy and after birth is a specific form of mourning, which has some unique characteristics compared to other tragic events. Knowledge of these variables helps to better understand the impact and the possible consequences in the lives of those affected. It is, in any case, an event that has a profound effect on the parental couple, on brothers, sisters, and subsequent pregnancies. It is essential that health professionals, doctors, psychologists, obstetricians, nurses, etc., acquire the awarenesses of the fact that the hospital is the first and in sometimes the only therapeutic setting processing of the loss, and are therefore prepared to manage adequately this situation. Well, the purpose of our research, the aim of this research is, in fact, to investigate the psychological dynamics present in parents affected by pre- or perinatal bereavement, and also introduce the suggestions for care practices to parents. Our methodology, the research proposed a critical and theoretical review of the international literature on pre- and perinatal mourning. Well, as of last century, the results, in brief, as of last century, with the significant improvement in Western countries of the living conditions and medical advances, in many countries of the world has gradually reduced the number of pregnancies, resulting in fatal outcome. the maternal mortality has decreased, and so the death in utero or intrapartum. These significant improvements have promoted a general culture of generative omnipotence. That is a widespread belief that everyone can have children, no matter how many attempts serve. This momentum of optimism is a totally unrealistic view of maternity path and pregnancy, and makes women and sometimes the staff called to care during this pregnancy absolutely unprepared from the psychological point of view to deal with this tragic eventuality. Technically, it defines perinatal death, the loss of a child that takes place between the 27 week of pregnancy and 7 days after giving birth. But the perinatal mourning can be extended to miscarriages, to the therapeutic termination of the pregnancy, to the fetal reduction in case of multiple pregnancies, or the intrauterine death of one twin, to the abandonment for adoption, and etc. Each of these situations presents specific aspects that need to be carefully analyzed. In any case, it is a very painful and difficult moment, regardless of the phase in which it occurs. The relationships with one child begins, in fact, before the birth, with the pregnancy itself that sets in motion the attachment bond between parent and child, based on an active exchange of psychic, sensorial, and biological stimuli. During the pregnancy, all the energy are polarized on forming a new life. When the project fails, the event processing, the acceptance of the mourning and the suffering are very, very difficult. It is, in fact, an unexpected event, but above all unnatural. The death of a child, in fact, reversing the unusual logic characterized by an increased vulnerability of women as a result of the important physical and psychological changes. The social response to these events often, unfortunately, is completely inadequate. It is difficult for our culture consider the abortion, especially in the early months of pregnancy, as a mournful event. We are a long speech of this, but I send to you later. The pre and the perinatal death has a catastrophic impact on the parental couple, and be a considerable risk factor for the onset of psychopathology in both parents. I examine this part in details. Well, synthetically, the loss of a child during pregnancy, a weakness in the mind of the woman and of the couple, feelings of inadequacy and aridity. Fantasies arise in parents linked to the presence of indelible genetic tear in the family. And in all cases, this event is for women a bizarre experience, because it is a death without an object to cry on, a blank tragedy. A blank tragedy hardly approachable because there are no memories to process. The dead child is a being that parents have not known, who has no history of life outside, but only in the mother's intimate sphere. When the woman must give birth to a deaf child, to the pain of childbirth is added the psychological suffering. The pain of childbirth is usually tolerated because attributed emotionally and cognitively to a higher cause, the birth of a child. But when the child is born dead, remains only the senseless pain experience that can have destructuring effects on the personality and expose the mother to the development of post-traumatic stress disorders. It is similar to have a painful experience of empathy, as it is Ben Robert. She was born, but there is nothing, there is the loss. Well, in synthesis, many parents, as happened to the victims of tragic trauma, can take days and weeks to realize what had happened. As soon as they are told what had happened, many enter into a kind of parallel reality and experience a painful state of dissociation. In the elaboration of the mourn, there are some significant differences between men and women, of which it is important to be aware in order to improve mutual understanding and availability, as well as relieve tension and conflict in the family sphere. It is not unusual that the loss of a child creates a marriage crisis. Most parents who have lost a baby before or after birth have difficulty finding someone willing to listen to the tragic experience that they have faced. Burdened by loneliness, the pain of the parents becomes uncommunicable and impossible to share. That is why the hospital and operators who are in front line to face the event have such an important role in these situations. Operators are experiencing feelings of sorrow for parents with which they identify deeply. For this reason, if not properly prepared, they tend to implement defense mechanisms similar to those of the pair. For instance, the minimization of pain and emotional isolation. Offer respectful listening to parents who face the tragic death of a child. Although not to diminish their suffering, it should at least share it with someone else. When the mourning concerns a pregnant woman and an unborn child, it is difficult for the woman and her partner have memories of the beloved object. For this reason, it is important, when possible, to show parents their child after birth, before it is taken away permanently from health personnel. Although this can be very difficult and painful for health professionals, it is an essential task that should be aligned with other welfare activities. The effort of doctors and midwives to accompany parents in meeting the dead child is due to the difficulty of encountering the death in a place that should be deputy to the celebration of a new birth, to the difficulty to stay close to the obscenity of the death in a place of birth. Nevertheless, the possibility of seeing their child helps parents to help parents to form the visual and tactile memories of one son, ascertain that their child was not a monster, exercise the fears of the parents to be bearers of indelible tear that will mark the next products of conception. Give a real face to the child imagined helps parents to overcome the trauma of mourning. Parents affected by perinatal death are extremely vulnerable and susceptible to every event and process. Take care of a couple who has lost a baby, therefore it requires careful not to add pain to pain, making gestures or using inappropriate words, and requires the use of simple and clear words, soft tones, and appropriate to the circumstances. The availability at listening and sympathetic presence. Take care of perinatal bereavement requires the operator listening skills of himself and of his emotions when faced with the death, and accompaniment participant but not intrusive. After the first phase, if properly supported and protected by the staff, mothers are able to focus on the different decisions to make, and they can make a personal contribution to all stages following diagnosis and prior to discharge. The well followed by the theme mothers, many decide to the best of their ability as giving birth, when giving birth, to see if and how the child, which diagnostic procedure to do. Give parents a chance to think what to do and decide. Giving them the right time and explaining the right options reassures them about their ability to have been able to handle that dramatic moment, and improves the work of mourning. The operator in the acute phase of shock has the duty to support the parent and to guide him without affecting his choices or choose in its place. He must inform him of all possibilities available, and for that reason should know the protocols on perinatal mourning carefully and all possible treatment options. The quality of care will be measured in terms of tolerability, and the event will be all the more bearable, the higher will be the level of support in the global sense. In conclusions, because I try to summarize, the assistance to parents affected to perinatal death is a very special moment, complex and emotionally relevant in clinical practice and many health professionals. The international literature provides ongoing support to the couple based on protocols of intervention involving intra and extra hospital figures. Respect and indisputable acknowledgement of the value of every life is critical to understand the pain of the parents and to act in a professional manner, but empathetic during all the stages of the procedure. The time of contact with the deaf child, I repeat, is a very important moment from the emotional and psychological point of view, because it establishes, as I told before, the belonging of that child, not imaginary, but real, to the family and to the mother in particular. It is a rite of passage that until recently was considered traumatic and therefore, unfortunately, avoided a priori. Actually, intimacy with the child, the experience of sharing and recognition that happens with him is essential for a proper work of mourning. Thank you for your attention. I'm sorry that I tried to summarize because the time is very short. If there are questions, I'm here. Thank you. Okay, thank you again.